Hi everybody, we're going to get into altered mental status for this training, specifically how it relates to and affects our treatment and assessment of the geriatric population. And we're going to roll through a good majority of our altered mental status protocol in the Southwest Ohio Protocol, which is pretty big. As most of you probably realize, it tends to snake through multiple parts and portions of the protocol. So this will be a good one for us. To make sure that we're kind of getting a all-hands-on look at something and really focus on our geriatric patients. So I'll give you a few minutes here. The protocol number is SB201 in the 2020 protocol. Should be page 36. So if you want to go ahead and start accessing that any way you want to and follow along, it'll probably help you out a little bit. So we're looking at our objectives here, pretty straightforward. We're going to define what altered mental status is, what it means to us, how do we differentiate the different diagnoses that cause altered mental status, and what do we do to treat each one. Pretty long discussion on a lot of this stuff. So, what is altered mental status? Well, it's the alteration in a patient's normal mental state. Their level of consciousness. It can range from mild confusions to comas. What causes it? Is it chronic? Is it acute? Is it organic? Is it a chemical cause? There's a lot that goes into this, and a lot for us to talk about with this. So altered mental status, we can roll through these variety of topics here very quickly. Is it altered? Are they a psychological patient? Do they have behavioral issues? And then divvies down into mental illness and disorder, or do they have some sort of developmental disorder? Autism, anything that could affect the brain, even the muscles, and the atrophy of how people tend to develop over, however long they've been alive. For the geriatric patient, which we're getting into now, really. We all go through this, and it's something that a lot of us probably have a fear of, or we know someone in our family that has this. Alzheimer's. Alzheimer's is a big fear for a lot of people. What are we dealing with? Is it dementia? Is it Alzheimer's? Is it something that's neither one of those, but maybe they suffer from one of those two things, and now we have to differentiate why is today any different than what their normal is. When we go on runs for these patients, for these geriatric patients, oftentimes you hear an experienced paramedic say, what's their normal? And what are we asking when we ask that? We're asking, we know that normally they are a little off, and they don't necessarily know what the year is. Or when we ask, who's the current president of the United States? They might be stuck in the 70s. We don't know. It really depends on our clinical experience and what the patient's family can tell us. A lot of times we can get a good reading on our patients based on what medications are they taking, what's been their recent dietary changes, medication changes, how many different doctors do they see, what's their medical history look like, what's their parents' medical history, did they suffer from dementia and Alzheimer's, and how quickly did they go downhill? These are all the things that we need to ask about our geriatric patients, because it can mean the difference between a routine run where maybe they're advancing in their unfortunate illness, but really is it going to kill them right now, which is really what we need to worry about, right? Or is it something more severe? Did they have a stroke? Have they taken too much of their medication? Some of the stuff that we're going to talk about and get into, those are the things that we really need to worry about. And that's really why this is such a hard topic for a lot of providers, and this can really make or break, a run for a family. So assessment, everyone knows these, right? So the H's and T's, we just did ACLS. This is a pretty big one for us, where we can really hone in and almost our bread and butter, right? Because everyone learns these and everyone knows these, and most of us know how to fix these. So we're going to talk about these as we flow through, and we're probably going to hit a lot of them, on repeat a little bit, because this protocol is so big and it hits so many different topics that it'll give us a chance to really dive into these. But I like this setup here, outlining, the different H's and the different T's, and give us signs and treatment all in one fell swoop there. So, this is really where we get into, I like the pictures, this is really where we get into geriatric patients. What's the difference? Why is one chronic and one acute? So, we talk about a confused geriatric patient. They're not just confused, right? They're confused for a reason. They're not just old and they don't understand, and we don't need to talk loud to them for them to understand better. The idea is to figure out what's wrong, and a part of that is us digging in deep into their history. So, a big, easy one for us to do is define whether or not this is chronic or acute. Dementia is chronic. Alzheimer's is chronic. Very gradual onset. They progress. Likely they know that they have a family history of this. It persists, and then as the disease progresses, then they slowly lose more and more of their mental state. Delirium is the one that we should be concerned with. It's sudden onset. It's a change that caused the mental status, right? Something changed in their body, changed in their environment, changed what they were doing, and now it has caused their mental state to alter. That's easy for us to really hone on, right? That's what we do. Most of us are A personality people. We're action-oriented people. We wanna fix bad change. Delirium is the bad change that we're looking for, that we really need to focus in and hone in on and try to change. So this is really where we get into geriatrics and deciding for when we get that altered mental status, Alpha, Bravo, Charlie, Delta, it doesn't matter. We get that, and then we need to decide, well, is it delirium? Is it acute? Or is this a chronic issue that they're suffering from? Here's some of the different, our differential diagnosis. We're clinicians. You guys hear me say this a lot. You do diagnose. You're smart folks. You train for a reason. There's a reason you go through all the training and have to go through everything that you do. It's because you diagnose. You have to. We use a protocol. We're lucky we have a protocol. We have something to look at that tells us, hey, if they're showing these symptoms, maybe you should try this. That's a great way to diagnose, honestly. We don't have to pull the rabbit out of the hat. We can just pull the already made up rabbit out of the already made up hat, and it tells us what to do, which is good, but we still have to pick between all these different things, and especially in altered level of consciousness, mental status, SB201 protocol, we really got to dig into it and pick stuff out of it. It's a pretty big protocol. So dementia, Alzheimer's, we talked about that stuff. Seizures, are they postictal? Different things that we can talk about for that. Strokes, different kinds of strokes. The hypo and hypoglycemia. Sugar problems. A lot of our elderly folks have sugar problems. Sepsis and infection. We're going to get into this one a decent amount, especially considering this current circumstances that we're dealing with. We're dealing with COVID-19 pandemic right now. It's a virus. Viruses cause sepsis. It's an infection of the body. It's causing pneumonia quite a bit. And so we roll on this patient that has altered mental status, and they have this acute, because they don't have anything wrong with them. Maybe they have diabetes, or they have previous history of an MI, and they have some comorbidities. But we roll in and we start doing our thing. We suspect COVID. Now we can't be so focused on COVID-19, calling the hospital. Maybe they're septic, and we need to start treating their sepsis also. So we can't get into the habit with all this that's swirling around us, and I know it's going to be easy to because there's so much going on right now. Let's not get caught up in the moment and miss a septic patient that we can actually make a difference on. So we'll talk about that one a decent amount. And obviously, there's encephalopathy and psychiatric disorders, and that's just to name a few. There are injuries, trauma. We're talking about just good old hypertension, ma'am, sir, do you have high blood pressure? Nope, I take a pill that fixes that, right? And we've all had that patient. So, but can that cause an acute or chronic version of altered mental status? Absolutely it can. Those are especially if it gets uncontrolled, or maybe they took a new med, or it's not working right, or you know what, it just makes me pee too much. I don't like going to the bathroom. Or we talk about the opposite end of not the hypertension. They're taking their K-Dor and they stop taking their medication. And then we have an electrolyte imbalance and maybe hypertensive issue. So there's lots of issues where we can run into this, and we can dig deep into this rabbit hole of this protocol. So here's where we're going to get into talking about the different assessments of what we're talking about here. And obviously this slide doesn't cover all of them, but it gives you something to look at while you're scrolling through the protocol and you're listening to me talk. So let's start here at decreased blood sugar, because I think this is one that we run on a decent amount, and it's one that most of us know how to fix, and I think it's a good starter. So if you roll down to 38 of the protocol, hypo and hyperglycemia are talked about there. So we're talking about, let's go ahead and talk about hypoglycemia, right? Because that's the one that we roll on pretty often, more often than not. And we can talk about that pretty quickly, I think. Hypoglycemic patients, we've all walked in. We've seen our hypoglycemic patients, like, oh, we might even know them, right, because we run them a decent amount. But we look at them, and they all kind of look the same. They all sweat a ton. They're usually cool to the touch, and they're kind of acting like they've had a bit too much to drink, right? So that's pretty straightforward. Then we get our glucose. It's less than 70, or the glucometer can't even read that low, and then we know what to do. Typically they're a hard stick. We fix it, okay? So how do we fix our hypoglycemic patients? Pretty straightforward. We give them sugar, right? So when you get a chance, when you get done with this training, make sure you look at your guys' drug bags and see what you have in there. Because likely, it's not D50, right? We're carrying the bags of sugar that we have to drip in slowly. Probably some debate and argument for that's better for the patient because we're not spiking them so high, but it is different. It's not what we're used to. It's not what we trained on. It's not what we learned. But it's good. It's sugar. We can fix that. If we can't get an IV, we can always rotate over to glucagon. Remember, glucagon's the one that if they get that, they really got to go to the hospital, because what does glucagon do? It dumps our glycogen stores, which means if something bad happens later on down the road, or something's causing their glycogen stores to dump, or, they're not taking their meds, or whatever it happens to be, they don't have anything to fall back on now. We've taken that and we've raised their blood sugar up for them by forcing this medicine to do that, but we can't leave them there. We really need to get that person to the hospital to make sure they're taken care of. Hyperglycemia, high blood sugar. So glucose is greater than 400. Glucometer reads high. How do these patients present? Well, these are our, we talk about it in the H's and T's about pre-existing acidosis. If they go into cardiac arrest, these are our folks that are really in the ballpark for receiving, if they're in cardiac arrest, they can receive sodium bicarbonate, right? So these are our pre-existing acidotic patients. How do we treat these folks? So treating hyperglycemia is pretty straightforward, right? We need to make sure that We're managing all their signs and symptoms. We need to get an IV access on them. How long have they been like this? Get them on capnography. Start really making a good assessment of what their respiratory drive is like. If they're acidotic, eventually, they're going to go down the road of becoming a cardiac arrest, because their body's going to try to get rid of this excess in acid in one way or the other, and eventually the body just can't keep up that long. So make sure we get a good reading on their capnography. Take a look at all your numbers, and then treat their signs and symptoms as you see them. And they're pretty straightforward. Fluid is usually a good thing for these folks. Let's do heart rhythm and disturbances, heart attacks. That's another one that, we just talked about that. We drew our nice picture, and we talked about what the heart does and how it runs through its whole assessment of keeping itself functioning on a normal basis. And honestly, this is kind of like the one that everyone is pretty good at, because it's the bad one, right? We do 12 leads. We're really good at 12 leads here, about taking them, and most of us are really good about reading them. Well, this is like the big one, right? This is like you get the medic card, it's fresh on the ink, you get an ST elevation patient, you transmit it into the doc, and you've really saved that person's life. Well, that's this. It causes altered mental status, especially in our geriatric patients who maybe don't compensate as well as we do. They don't handle hot and cold as well as we do. All that stuff affects how maybe they're handling a dysrhythmia of their heart. Eventually, if we all live to be old enough, we'll all go into atrial fibrillation. Maybe they built up a clot. Maybe they didn't know they had AFib. Maybe they threw a clot and they have a dysrhythmia along with maybe a PE or a stroke. So dysrhythmias are important for us to look at. When we get our geriatric patients who maybe are on Coumadin and their blood sugar's reading 60, and they're on metoprolol. We see all these different things, and we just talked about 2 different altered mental status possibilities. Which came first, the chicken or the egg? We don't know, and that's where we really gotta put in the work to do a 12 lead and get a blood sugar and get a good family history and find out what's changed recently. Was this a sudden onset? Have they been progressing over the last 2 weeks, over the last 2 months? And find out what's going on there with this. You all are very good at reading 12 leads and dysrhythmias. We just did ACLS, but don't discount the fact that just because they're old and just because they're altered, that it's always a sugar problem, or it's always that they're getting just dementia. They have Alzheimer's, or don't jump straight to infection. Do a good job. Make sure you get in there and move their skin around to get a good 12 lead, and take a look and make sure that we're not missing something. This is the patient that we could easily miss something on because we take it for granted. I know I have. That's for sure. So we already talked about electrolyte imbalance a little bit, and that's honestly an easy one for us to roll through, especially with our dementia or our geriatric population. They all get finicky. We all dealt with our grandpa and grandmas before. They eat bacon and eggs every morning for breakfast, and they're very stuck in their ways, right? My grandpa used to, when he felt his blood pressure getting low, you guys can't see me, but I'm doing air quotes, his blood pressure would get low, and how he would fix that is he would grab his salt shaker, and he would put a tablespoon of salt in his hand, and he would lick it off his hand, and that's how he fixed his blood pressure. Never mind the fact that he took blood pressure medicine to lower his blood pressure, and that's just what some of our geriatric population do, because change is scary, right? They start getting to this point in their life. Sorry about that. I didn't want the run to interrupt the recording. So they start getting to this point in their life where they're having lots of changes that probably scares them, and rightfully so. Most of them, unless they were born with some sort of chronic disease, grew up, worked a full life, had kids, watched their kids have kids, retired, and that's a big change for people, is to go from being busy and having things to do as opposed and being able to worry about other people maybe, and now they suddenly, everyone's grown up around them and they're taking, that's us, we want to take care of ourselves and be responsible for our lives, and now they feel like they have this sense of duty that they still want to take care of people, but they don't want to take care of themselves because they don't need to yet. And it's that part of that denial where they come in and they start taking these meds because the doctor says they have high blood pressure, or, their sugar's just not looking right. Their labs don't read great, or maybe they haven't been to the doctor and because they don't believe in going to the doctor. Those are all normal things for our older generation. And it's because change. None of us like change all that much, realistically, especially when it comes to how we live our lives and how much we like to do with our lives, They have to change the way they do that, and it scares them. And that's okay. And we need to be cognizant of that and not get frustrated with them. So, when we're talking about our electrolyte imbalances, that may be it, because that doc gave them the new medicine because they hadn't been in a couple years and they found something wrong, so they tried to fix it. Well, the classic one we already kind of mentioned is their water pill. Their water pill, which is realistically a high blood pressure pill that they get with maybe K-Dor to keep their potassium up because it depletes their potassium levels. Well, they keep taking the K-Dor, but they don't like how often they have to get up in the middle of the night and use the restroom. Easy electrolyte imbalance, right? Peak T waves possibly. They're just not acting right. Supportive care. Start an IV. Make sure we're taking good care of them. Keep them warm. Get them to the hospital. Get an assessment on how many meds have they taken. When did they get prescribed to them? Just like we do with maybe some of our folks who have an intent on hurting themselves. We do the same thing. Like, oh, okay, we should look and see how many pills they have and then compare it to when they got that prescription filled. We could do the same thing with our elderly people. We can take a look at everything and say, ooh, maybe he's not taking as much as he's supposed to. And he's taking all of his K-Dor, or whatever the medicine happens to be. Hypothermia, hyperthermia, so we can talk about heat emergencies. In our elderly patients, this is a big one. They don't regulate heat as well as we do. As we get a little bit older, and most of you know me, I don't like being cold at all, and I'm in my 30s. As we get older, I'm imagining it's going to get worse, because I've been to geriatric folks' home in our community, and they have the heat cranked up, and they're still covered in blankets, and they're like, will you cover me in a blanket before you take me outside? And it's an 85-degree day out, right? That's not them being picky. That's just the body. That's the body changing. And can it affect their mental status? Absolutely. So if we think about our normal healthy people who get into water, even when it's not, we always think of the altered mental status, people losing their lucidity because of it's cold and they fell through the ice. Well, that can happen in still or more often in moving water in the spring and in the fall, when the water is really not cold per se, but it's cold enough to move heat away from the body very quickly. This happens with our geriatric people when they're sitting in their homes, or they go to their kid's house or their grandkid's house, and they go over, and if you're like me, I don't turn my heat on and I don't turn my air conditioning on because, well, I'm cheap, and it drives my wife nuts. But the fact is when my grandpa comes over and he says he's cold, that's usually his indication of telling me, hey, Chris, do you mind turning the heat up, because it affects him differently than it affects us. And if he stayed there for a long period of time because maybe he can't afford it because he's on a fixed income, or he lost his job, or his wife recently died and she was really the breadwinner, and maybe they're working out through all the legal stuff that he has to deal with, and they don't have heat. If he didn't have anywhere else to go, then maybe that changes his mental status. And how do we fix that? Pretty easy. If it's not severe, get him out of the environment and put him in an environment where we can slowly warm them up or slowly cool them down. So hypothermia patients, pretty easy, right? Get them out of the environment, warm them up slowly. We don't want to jar them. If they're in cardiac arrest, however, that changes things a little bit. We really need to be cognizant of what we're doing to our hypothermic cardiac arrest patients. That is really a whole nother training, but for the most part, get a look at your protocol, and it's 1 round of ACLS drugs, 1 shock, and then they're not dead until they're warm and dead, like we've always said, right? So use your Lucas machines, do the right thing, take the time to do it. Hyperthermia. So hyperthermia patients, they have the three stages that everyone knows, right? So obviously the bad one is heat stroke. Heat stroke is when they've stopped sweating, but are we going to really know that they've stopped sweating? No, because they transitioned from heat cramps to heat stroke, and they went through all of those phases with or without us there, and they have sweat on them. So we need to determine what's going on. Realistically, the biggest indication for us for a heat stroke patient is altered mental status. Their body is not regulating it as well as we may be able to, and they can't handle the heat like we can. They're getting dizzy, they're falling down, they might dehydrate really fast because they don't like water, right? My grandma loved iced tea, sugared iced tea, lots of sugar iced tea. Probably not the best thing to be drinking on a 95-degree day, but they're stuck in their ways, right? They don't like change. They don't like drinking as water as much as we do. None of us really like drinking water all that much. So keep that in mind. Cool them down. This is probably the one time we talk about warm IV fluids a lot for our patients, and it's really good for everybody. The hyperthermic patient is probably the patient we should not be using warm IV fluids on. It's really the only patient. It's actually counterintuitive. But get them cooled off, strip their clothes, spray some water on them, get a fan on them, passively cool them, get them cooled down. But don't overcool them. They just don't regulate heat like we do. Let's bounce over here to infection. Infection. So big one, right? This is the one that we're all kind of dealing with right now as a nation, and especially here in Butler County. We have quite a few cases. We need to be cognizant of our infectious patients, specifically what's going to cause a altered mental state in our geriatric patients due to infection. It's when they've progressed into sepsis. We've all studied sepsis quite a bit and realized just how bad it is, and maybe how many times we had unfortunately missed it. But that being said, now we're here and we're talking about it. Well, now we have a pandemic that could potentially cause quite a bit of it. We know that COVID is really affecting our elderly population. It's affecting everybody, but it really hits our elderly population pretty hard, especially if they have comorbidities. If they have CHF, if they have COPD, maybe they're just an asthma patient their whole life. Sugar problems are bad for the whole body. Are they a diabetic of some sort? Not good. Have they had heart attacks before? Have they ever had a stroke? Are they on lots of medications? All these things can lead them to be susceptible to becoming the very serious COVID patient that now we have to deal with, right? And it adds an extra layer for us. So when we talk about sepsis in our geriatric patients, and we're dealing with someone who's obviously in dire need of our help and eventually the ER and probably ICU, now we have to worry about putting our stat packs on, getting our goggles on. Our scout has to recognize it pretty quickly because they have to get geared up and get in there by themselves. We really got to focus on this stuff, and this could be an easy one for us to miss, unfortunately, because we have so much going on. And we can get tunnel vision pretty easily. So let's talk about sepsis. So sepsis affects all ages, obviously not just geriatrics. We just happen to be talking about geriatrics for this training. So for sepsis, remember that we need to suspect that the patient has an infection. So they have to have a source along with one of the other signs and symptoms that we may find. So if we suspect they have a source, in COVID specifically, typically pneumonia, but maybe they're in the in-law suite and they haven't been rolled around in a while. They've got a bed sore that could easily cause it. Stomas, anything like that. UTIs are a big common cause of the source, but suspect a source. So now we need to worry about the signs and symptoms and where they're showing. Well, obviously they're probably going to be a little warm to the touch. Late stage sepsis shows as cold. They tend to get a little chilly. So your range there, and this is pretty easy since we're dealing with, we're talking about fevers quite a bit right now with the pandemic. But for the protocol, 100.4 or greater is our cutoff for our temperature. And then if they're less than 96 degrees, that's really bad. They're in late stage sepsis. That's not good. That's a problem, right? And so for some of the newer folks, 96 degrees and 104 really aren't that bad, right? Because 98.6 is perfect. That's our homeostasis for temperature. Well, a little change can go a long way when we're talking about temperature specifically. Those numbers don't need to change much for us to be, this isn't good. So realize that. So don't get caught in that loop. For adults, since we're talking about geriatrics, which I don't know if I mentioned 65 and greater, so I'll mention that a couple times over the next 15 or 20 minutes. That way I get that in there. But 65 and greater is our geriatric population. But blood pressure is stated in the protocol as less than or equal to 90. Well, what do we know about our geriatric patients? Well, they don't compensate like we do. Sometimes they're on a beta blocker and their heart rate's controlled for them. So maybe they don't fight off this infection quite as well or compensate for the growing infection to counteract the loss in blood pressure with their increase in heart rate because they can't, because they have medications on board. That's a problem, right? That causes issues for us because we get there and we find this patient who's not doing well. They're very hot to the touch. Their blood pressure's not good. It's less than 90. And their heart rate's at 64. Why? Well, they're on a beta blocker. They can't compensate. That's not good, right? That we need to recognize that. And that's an extra layer of digging that we have to do to really treat our geriatric patients a little bit better. They're probably already breathing a little bit fast or get a little worked up, a little easier than the rest of us, because as we get older, our knees start to hurt a little more, our backs start to hurt a little more, waking up sore in the morning. So do they do as much exercising? Probably not. So they're just not going to compensate as well. Heart rates greater than 90. Probably pretty easy to do for some of our elderly patients, unless they're on those beta blockers, those heart controlling medications. But if they're not, and maybe they have coronary artery disease, they don't eat well, they don't take care of themselves, they've had a whole generation of Big Macs at their beck and call, they might have those issues. They might have a high heart rate on a regular basis, and that may be their normal. Respiratory rate greater than 20, which kicks right in with end tidal. End tidal is going to be less than 25. So if their respiratory rate's high and their end tidal's low, that means they're breathing off too much CO2, right? That's one of our biggest indicators. And then obviously the last one is what we've been talking about for the last 35 minutes and 20 seconds. Altered mental status. So they are altered. Altered should be one of the biggest ones for us when we go on any patient that we have a serious run. And we should assume that it's a serious run until proven otherwise. So how do we treat our sepsis patients? Fluids are good. Early fluids are good, and warm IV fluids. We know that they tend to have a fever, but we want them to absorb this fluid quickly because this is a distributive shock. So they're losing, they could be in compensated, decompensated shock, all within their container. And nothing's really leaking outside of the container. It's just not where it's supposed to be inside the container. So make sure we focus on our fluids. We really need to keep their fluid levels up. Try to get it above 90, above 100. Get their kidneys perfused, their heart, their lungs, and their brain. Remember, those are the 4 big ones that we talked about in ACLS. When we're talking about any patient with a blood pressure problem, we've got to perfuse those 4 things. Because if we don't, then we got issues later, right? We have multi-organ dysfunction syndrome. MODS. We have MODS that they end up passing away from because we got them to the ER alive, but they bought a ticket to an admission. The admission didn't go well because, well, their kidneys weren't properly perfused. Sorry, I'm playing catch up with the protocol here to make sure that I can follow along with you. So hopefully so far this has been helpful, a good reminder about just talking about our geriatric folks. They really are a different population themselves, and they're a pretty important population, for us to worry about because we have a decent amount of them. They make up a good majority of our country right now. All right, so head injuries and just trauma in general for our geriatric patient, our population, is not good. They, again, don't compensate well. They don't take hits as well as we do. So when we have our geriatric trauma patient, greater than 65 years of age, remember they have to go to a trauma center. Have to. And we need to be cognizant of that if they're involved in any sort of trauma, that we really need to be vigilant about making sure that we are doing the right thing for them and ensuring that we're not going to make this worse. So that's the trauma guidelines are in the protocol, and it's a Ohio dictated thing. Captain Nolman did it last year for our trauma triage guidelines, and it specifically hits on our geriatric population for that specifically. But for our head injury patients, and we're talking about the geriatric population, what happens to the brain when we get older? Well, it tends to shrink as we get older. So if someone gets even in a minor car accident, or they're having lots of falls because they're having syncopal episodes, and syncopal episodes can be a whole 2-hour training in itself because of the different things that can cause that. But this brain now is shrunk, and then obviously the skull doesn't shrink. But we have Captain Limerick's favorite saying, coup contra coup, right? Where some sort of traumatic event happens, forcefully causing their brain to move forward and or back. First, it strikes the skull, they move again, it strikes the front, and then it continues to bounce and bruise and bang. And maybe sometimes that springs a leak. That's a trauma injury to the head, right? TBI. Not good. We know how well our patients in general recover from hemorrhagic strokes. Now we have a traumatic event caused in a geriatric population. It's good for us to pick up on that pretty quickly and about what to do. So what do we do? Obviously, we need to recognize that we have an issue with the head and really start focusing in on this. But can we give some sort of hypertonic saline to our TBI patients? It's got to depend, right? Do they meet the proper? Do they have all the signs and symptoms of cerebral herniation, which is really the big indication for us whether or not this patient needs to have us intervene. So our interventions for cerebral herniation, TBI, is hypertonic saline. Making sure that we're controlling our capnography level. So if we're talking about this, we need to be aggressive. We need to have someone get on the airway quickly, monitoring capnography, and we want to ensure that we are not hyperventilating, but we're keeping them at the low end of their normal. Aggressively treat that airway, and if taking the airway is what's going to allow us to better control that capnography, we need to do that. Then we need to jump and have somebody get into the hypertonic saline and really look at it, and are we having the beginning signs of cerebral herniation? So are they having some sort of posturing, bilateral or maybe unilateral pupil movement? Now they're blowing up. That's not good. Now we're having pressure forced from the brain, down onto the base of the skull, and it's forcing out that small little hole, and now it's going to start affecting everything. And we got to try to hold that off as best as we can by the two big things: airway and then hypertonic. So the hypertonic is 500 milliliters of 3% saline, if it's available. Obviously, it's in our drug bag. So if you find that we have an elderly patient who suffers from a TBI and they're showing these signs and symptoms, do not hesitate to jump in on that. Make sure you're doing it. So if they don't have a TBI and they just have a trauma patient, still 65 years older, they follow the guidelines, all that stuff. But also, what else do we have at our disposal for just the trauma patient in general? Don't forget about TXA for our elderly patients. TXA can be a pretty useful drug, and all the studies are in the protocol on LinkedIn, so you can read all of that stuff. Just realize that there is a small caveat there, that if you happen to have the trauma patient, geriatric or not, and they're suffering from a TBI, that's a contraindication. So just make sure you read through that, give it a good look, and we're going to be hitting that again. So let's hit some strokes. We'll talk about the different kinds and potentially where they're at and located in the head, and this can relate to TBIs also. But we talk about our stroke patients and hemorrhagic and ischemic. Our ischemic strokes are the embolism, the clot breaking loose from somewhere, typically the carotids jumping up into our brain, blocking something off, and then we go through our whole assessment, and we decide, that, hey, this is a true blue stroke patient, and we need to get them to the appropriate facility so they get the appropriate treatment. And then our hemorrhagic folks, which are the smaller percentage of strokes, but the much more fatal ones, unfortunately, that they present, and when you see one, typically, you don't forget that, right? Those are the folks that really shine out in our heads as far as the bad off patients that we've seen before, and like, man, this is not good. So sometimes those might be the easier ones to pick out, depending. It was a very sudden loss of consciousness. They were complaining of a really bad headache, and then boom, grandma, grandpa are out, and they're out cold. And they're just not responding to anything. They're sweating really bad. They just don't look good. They look ill. Sometimes, unfortunately, that is the cause. So occasionally we'll get a slow one, subdural bleeds. So they're slow. There's a period of unresponsiveness, and then they become lucid again. They might be a little confused, and then they'll go back to being unresponsive. And those are our subdural bleeds. And then you could have a subarachnoid bleed, and this could be trauma, or unfortunately, they're having their hemorrhagic stroke. But also, the subarachnoid bleed is bad. It's much quicker usually. They have neck pain. And these tend to be our strokes that vomit pretty violently, and then even sometimes they spike a fever. And those can be the big clues that can jump up at us and say, ooh, maybe this person had this sudden delirium, right? Delirium is that sudden change that causes their altered mental status. Son or daughter, grandkids say, oh, they were complaining of this, this, and this. He had some neck stiffness. He vomited really bad, and then, he felt really warm to the touch. Maybe it's not meningitis. Maybe they had a stroke. So don't immediately rule that out. It's not a bad thing to look into. At least consider and keep it on the table of your diagnoses of what could be going on with our patient. We get into shocks, different kind of shocks, and really the one that we haven't talked about, because we talked about stuff leaking out of the tank, talking about the pump not working, anaphylactic shock, allergic reactions. That's one that we're all really good at picking out. Someone's allergic to something, someone's allergic to something, we fix it. So run through the normal procedures for treating someone with an allergic reaction, anaphylactic shock. It really doesn't change much. What might change for that person in particular is maybe their breathing treatment, because maybe they're a COPD patient, maybe they're an asthma patient, and they know that albuterol doesn't work on them. They need DONEB. Listen to them. They know themselves better than you do. They might have an EpiPen, but Epi's going to be that's what's going to reverse it, and we can keep our Benadryl going, get it in there, and make sure we stop it from getting any worse, and then really listen to them. Like, albuterol doesn't work on me, and try something else. Last one we're really going to get into here before we move on and finish the training up here is the medication related stuff. And we kind of already talked about it with beta blockers, but when it comes into terms with overdose, which is one of the altered mental status we haven't talked about, we talk about medication related. Accidental overdose in our geriatric patients can be a common thing. They have back pains, they hurt themselves, and they accidentally take too much, or maybe they are the dementia patient, Alzheimer's patient, and they forgot how much they took for the day, or they didn't realize today was Monday, and they took, Tuesday and Wednesdays also, along with their Monday care meds. So it's not just a young person's game to have pinpoint pupils and slow breathing. Sometimes it's accidental. And obviously the treatment is Narcan. It's a pretty straightforward, easy treatment to get through. As we move on into in our PowerPoint here, it's got a nice excerpt from the protocol itself, which you probably have already looked at. It gives you a nice little algorithm there for how we can run through this and generically look at all of our altered mental status patients. This obviously isn't just for geriatrics, but it's a nice start. But there's lots of avenues for us to dive down and go into. For our treatment and care, we talked about all those specifics as we rolled through each individual one. But safety is always paramount for us, because sometimes the one that we didn't really talk about the whole lot is our behavioral patients who are altered. Behavioral emergencies are emergencies, and unfortunately it tends to involve harm to themselves and or us, and realize that we need to keep ourselves safe first so we can help that person. Staging, waiting for PD, using chemical restraint at times, physical restraint, but the biggest thing is, be a whisperer of the folks that aren't all there with us right now at the moment. Try different techniques. Try to relate to them, engage them, be open to talking about different things with them and be understanding. And maybe they're not having a behavioral issue. Maybe they're just getting older and their body's not working like it used to because they have now crossed over into that geriatric population. They're 65 and older. They're taking new meds. Their body's not working like it used to. And they're angry. Maybe they have a drinking problem. Maybe their wife or their husband just died. Or, God forbid, one of their kids. Be open to really talking to these patients. Because a lot of times, and I know most of you know this, but talking to them is one of the biggest treatments we can do for these folks. Sometimes that's all they need is an ear. We don't have the nursing homes that some of our neighboring departments have where they get really good at talking to our geriatric patients because they run on them a lot and they get a chance to really talk to them. So when we get them, I think, at least for me, sometimes I can get into that motion of what's wrong, and trying to really dig down and find out what's going on with this person. Realistically, all they need is for me to shut up and just listen to them. And that is going to cure some of the problems. And then they're going to tell you exactly what's wrong. And maybe we get to learn something while we're at it. So these are all the protocols that not all, these are a lot of protocols that we touched on for altered mental status. And as you scrolled through up and down the protocol with me, hopefully, you realize that this is a big one. It touches a lot of different things and hits on a lot of the different patients that we run on. And there's no way that I covered all of this in this hour. It's just not possible. There's just a lot to go over. And this is hopefully a good introduction for you to do some self-study and really look at this. And there's probably stuff in here that I missed, got wrong, or didn't realize was in there in the first place. And I think that's a good way for us to jump into this as a cruise and really talk about maybe past experiences that you've had. This is great that we can get some training out to you, but we miss the engagement with each other and hearing each other's stories about, well, this one time this happened, and I messed this up, and I learned from that, and that's hard to recover. But you guys can do that right now, and I encourage you to please, talk about these different protocols, and it'll probably spark memories of a run that you'll never forget and that the new person sitting next to you or the old person sitting next to you can learn from. So in summary, altered mental status is the alteration of the patient's norm. Our job really comes down to coming in and deciding, is it chronic or is it acute? It changes a little bit for our geriatric patient, right? It's sick or not sick. Well, you walk in and somebody's altered. Well, they could be sick, but is this their normal? And then so it really needs to become, is this something that's normal for them? What's their normal? Or have they had some sort of physiological change that's caused their mental status to change? And then we really got to get into our appendix and library of the protocol here and figure out what's going on and then treat it appropriately. I hope that this has been informative. I hope that it's been at least the spark to a good discussion amongst the crews. This will be a geriatric training. Thanks.